Good day. The topic of lecture is anatomy and topography of stomach and its digestive glands, small and large intestine, peculiarities in children.
We will consider following questions: anatomy and topography of stomach, peculiarities of stomach structure in children, anatomy and topography of small and large intestine, and children peculiarities of small and large intestine. The stomach is expanded part of the digestive tract between the esophagus and small intestine. The stomach acts as a food blender and reservoir. Its chief function is enzymatic digestion. The gastric juice gradually converts a mass of food into the semi-liquid mixture chyme, which passes very quickly into the duodenum. The stomach consists of four parts: cardia, fundus, body of the stomach, and pyloric part. Cardia, the part surrounding the cardial orifice, the superior opening of the stomach. In the supine position, the cardial orifice usually lies posterior to the thick left costal cartilage, 2-4 cm from the median plane at the level of the 11th thoracic vertebrae. Fundus, the dilated superior part that is related to the left dome of the diaphragm, and is limited inferiorly by the horizontal plane of the cardial orifice. Body of the stomach, the major part of the stomach between the fundus and pyloric antrum. And fourth part of the stomach, pyloric part, the funnel-shaped outflow region of the stomach. Its wider part, the pyloric antrum, leads into the pyloric canal, its narrow part. The pyloric is the distal sphincteric region of the pyloric part. It is a marked thickening of the circular layer of the smooth muscle that controls discharge of the stomach contents through the pyloric orifice into the duodenum. The stomach also features two cavities. Lesser cavity forms the shorter concave right border of the stomach. The angular incisor notch, the most inferior part of the cavity, indicates the junction of the body of the stomach and pyloric part of the stomach. And greater cavity forms the longer convex left border of the stomach. The stomach wall has following tissue layers: mucosa, muscular layer, and serosa. Muscular layer consists of external longitudinal layer, middle circular layer, and internal oblique layer. When contracted, the gastric mucosa is thrown into the longitudinal ridges or wrinkles, called gastric folds. They are most marked towards the pyloric part and along the greater cavity. During swallowing, a temporary groove of furrow-like gastric canal forms a longitudinal gastric folds along the lesser cavity. It can be observed radiographically and endoscopically. The gastric canal forms because of the firm attachment of gastric mucosa to the muscular layer, which doesn't have an oblique layer at this site. The surface of the mucosa is a simple columnar glandular epithelium. The apical regions of its surface cells are filled with methane. After it's secreted, methane swells with water and becomes mucus. The gastric mucosa is pocked with depressions called gastric pits, lined with the same columnar epithelium as the mucosal surface. 2 or 3 tubular glands open into the bottom of each gastric pit and span the rest of the lamina propria. In the cardiac and pyloric regions, they are called cardiac glands and pyloric glands, respectively. In the rest of the stomach, they are called gastric glands. Mucous cells, which secrete mucus, predominate in the cardiac and pyloric glands. Regenerative stem cells, found in the base of the pit and neck of the gland, divide rapidly and produce a continual supply of new cells. Parietal cells, found mostly in the upper half of the gland, secrete hydrochloric acid and intrinsic factor. They are found mostly in the gastric glands, but a few occur in the pyloric glands. Chief cells, so named because they are the most numerous, secrete chymelin and lipase in infancy and peptinogen throughout life. They dominate the lower half of the gastric glands, but are absent from cardiac and pyloric glands. Enteroendocrine cells, concentrated especially in the lower end of a gland, secrete hormones and paracrine messengers that regulate digestion. They are found in all regions of the stomach, but are most numerous in the gastric and pyloric glands. These cells secrete a hormone called gastrin, which stimulates the exocrine cells of the gastric glands to secrete acid and enzymes. Holotopy of the stomach. 3/4 of the stomach located in left hypochondrium and 1/4 of the stomach located in epigastric area. In this slide you see different variations in position and contour of stomach depending from the body habitus. You see hypertonic, orthotonic, hypertonic and atonic stomachs. Skeletopy of the stomach. Cardiac orifice located on level of the 10th, 11th thoracic vertebra, and pyloric orifice located on the level 12th thoracic and 1st lumbar vertebra at right side of vertebral column. Relations of stomach. Anterior wall of the stomach is related to the diaphragm, the left lobe of liver, and the anterior abdominal wall. Posterior wall of the stomach is related to the transverse colon, pancreas, left kidney and left adrenal gland, and spleen. Arterial blood supply. The rich arterial supply of the stomach arises from the celiac trunk at its branches. Most blood is supplied by anastomosis, formed along the lesser cavity by right and left gastric arteries, and along the greater cavity by the right and left gastroomental arteries. The fundus and upper body receive blood from the short and posterior gastric arteries. Venous drainage. The veins of the stomach parallel the arteries in position and course. The right and left gastric veins drain into the hepatic portal vein. The short gastric veins and left gastroomental veins drain into the splenic vein, which join the superior mesenteric vein to form the hepatic portal vein. The right gastroomental vein empties into the superior mesenteric vein. A prepyloric vein ascends over the pylorus to the right gastric vein. The gastric lymphatic vessels accompany the arteries along the greater and lesser cavities of the stomach. They drain lymph from its anterior and posterior surfaces towards its cavities, where the gastric and gastroomental lymph nodes are located. The efferent vessels from these nodes accompany the large arteries to the celiac lymph nodes. The parasympathetic nerve supply is from the anterior and posterior vagal trunks and their branches, which enter the abdomen through the esophageal hiatus. The anterior vagal trunk, derived mainly from the left vagus nerve, usually enters the abdomen as a single branch that lies on the anterior surface of the esophagus. It runs towards the lesser cavity of the stomach, where it gives off hepatic and duodenal branches. The rest of the anterior vagal trunk gives rise to anterior gastric branches. The larger posterior vagal trunk, derived mainly from the right vagus nerve, enters the abdomen onto the posterior surface of the esophagus and passes towards the lesser cavity of the stomach. The posterior vagal trunk supplies branches to the anterior and posterior surfaces of the stomach. It gives rise to posterior gastric branches. The sympathetic nerve supply from the 6th, 9th thoracic segments of the spinal cord passes to the celiac plexus through the greater splenic nerve and is distributed through the plexus around the gastric and gastroomental arteries. Peculiarities of stomach topography in children. Stomach of newborn has more vertical position located on left from the middle line. Pylorus is located in midline plane, or a little on right from it. Large cavity lays on a caudal position. and after 4 years old, stomach has a constant position of adult person. Peculiarities of stomach structure in children. Stomach of newborn is not completely formed. Fundus, cardiac, and pyloric parts are weakly expressed. Pyloric part looks developed up to 4-6 months, fundus up to 10 months. There is positine at infants due to the not developed cardia, formation of which is finished only to 8 years old. Volume of stomach cavity in newborn is 7 milliliters. After 1 day, it increases in 2 times. After 2 days, in 4 times. After 3 days, in 7 times. After 7-10 days after birth, the volume of the stomach is 80 milliliters. In newborn, mucosa is thick with much folds. Gastric glands are weakly developed. Submucosal layer is reached by blood vessels, has less connective tissue. Muscular layer is not enough developed too. External layer is thin, middle circular layer is most thick and forms pyloric sphincter. Serous layer is peritoneum. Gross omentum is short and thin. Small intestine consists of the duodenum, jejunum, and ileum. It is the primary site for absorption of nutrients from ingested materials. It extends from the pylorus to the ileocecal junction, where the ileum joins to the cecum. The duodenum, the first and shortest part of the small intestine, is also a widest and most fixed part. The duodenum pursues a C-shaped course around the head of the pancreas. It begins at the pylorus on the right side and ends at the duodenojejunal flexure on the left side. This junction occurs approximately at the level of the second lumbar vertebra, 2-3 centimeters to the left of the midline. The duodenum is divisible into 4 parts. Superior part, short and lies anterolateral to the body of the first lumbar vertebra. Descending part, longer and descends along the right side of the first, third lumbar vertebra. Horizontal part, crosses the third lumbar vertebra. And ascending part, short and begins at the left of the third lumbar vertebra and rises superiorly as far as the superior body of the second lumbar vertebra. Duodenum. Internally, the duodenum exhibits transverse to spiral ridges, up to 10 mm high, called circular folds. They cause the chyme to flow on a spiral path along the mucosa, slowing its progress, causing more contact with the mucosa, and promoting thorough mixing, digestion, and nutrient absorption. Adjacent to the head of the pancreas, the duodenal wall has a prominent wrinkle called the major duodenal papilla, where the bile and pancreatic ducts open into the intestine. This papilla marks the boundary between the foregut and midgut. In most people, there is a smaller minor duodenal papilla, a little proximal to this, which receives an accessory pancreatic duct. The arteries of the duodenum arise from the celiac trunk and the superior mesenteric artery. The anastomosis of the superior and inferior pancreatic duodenal arteries occurs between the entry of the bile duct and the junction of the descending and horizontal parts of the duodenum. The veins of the duodenum follow the arteries and drain into the hepatic portal vein, some directly and others indirectly, through the superior mesenteric and splenic veins. The lymphatic vessels of the duodenum follow the arteries. The anterior lymphatic vessels drain into the pancreatoduodenal lymph nodes and into the pyloric lymph nodes. The posterior lymphatic vessels pass posterior to the head of the pancreas and drain into the superior mesenteric lymph nodes. Efferent lymphatic vessels from the duodenal lymph nodes drain into the celiac lymph nodes. The nerves of the duodenum derives from the vagus and greater and lesser splanchnic nerves, by way of the celiac and superior mesenteric plexuses. The second part of the small intestine, the jejunum, begins at the duodenojejunal flexure, where the digestive tract resumes an intraperitoneal course. The third part of the small intestine, the ileum, ends at the ileocecal junction, the union of the terminal ileum and the cecum. Most absorption of the end products of digestion takes place in small intestine. This process of absorption requires a large surface area, which is provided by several structural modifications of the small intestine. First, circular folds are microscopic folds of the mucosa and submucosa. Second modification, the villi, which give the inner surface of the intestine a velvet-like appearance. Each columnar cells, except the mucus-secreting goblet cells of the villi, also has microvilli on its free surface. These microvilli are microscopic folds of the cell membrane and are collectively called the brush body. All these folds greatly increase the surface area of the intestinal lining. The superamesenteric artery supplies the jejunum and ileum via jejunal and ileal arteries. The superamesenteric vein drains the jejunum and ileum. Specialized lymphatic vessels in the intestinal villi, lectils, empty their milk-like fluid into the lymphatic plexuses in the wall of the jejunum and ileum. The lectils drain in turn into the lymphatic vessels between the layers of the mesentery. Within the mesentery, the lymph passes sequentially through the three groups of lymph nodes: juxta-intestinal lymph nodes, mesenteric lymph nodes, and supracentral nodes. Efferent lymphatic vessels from the mesenteric lymph nodes drain to the superamesenteric lymph nodes. Lymphatic vessels from the terminal ileum follow the ileal branch of the ileocolic artery to the ileocolic lymph nodes. Age peculiarities of small intestine. Length of duodenum in newborn is 7.5–10 cm. In first years of life it has annular shape. Length of intestine of newborn is more than in older children. Relation of length of intestine to the newborn body height is 8:1, in 1 year infant 6:1, and in adult age 4:1. Relation of the length of small intestine to the length of large intestine and newborn is 5:1. Mucosa, submucosa, and muscular layers has same widths. Number of folds and villi is less than in adults, and mucosa is good vascularized. Peculiarities of topography of small intestine in newborn. Small intestine is located higher in abdominal cavity than in adults. That's why some pelvic organs are present in abdomen. To the 7th month of life, these organs have position of adult. Large intestine extends from the distal end of the ileum to the anus, a distance of approximately 1.5 meters. It absorbs fluids and salts from the gut contents, thus forming feces, and consists of the cecum, appendix, colon, rectum, and anal canal. The large intestine can be distinguished from the small intestine by amental appendices, small fatty amentum-like projections, taenia coli, 3 distinct longitudinal bands, mesocolic taenia, amental taenia, and free taenia, haustra, circulations of the wall of the colon between the taenia, and a much greater caliber. In this section, the ileal orifice enters the cecum between ileocolic lips. The circular muscle is poorly developed around the orifice. The orifice is usually closed by tonic contraction, however appearing as the ileal papilla on the cecal side. The papilla probably serves as a relatively passive flap valve. The appendix is a blind intestinal diverticulum that contains masses of lymphoid tissue. The appendix has a short triangular mesentery, which derives from the posterior side of the mesentery of the terminal ileum. The position of the appendix is variable, but it's usually retrocecal. In the table, you see the distribution of blood supply of large intestine. Ileum, cecum, appendix, ascending colon, and transverse colon has blood supply from the superamesenteric artery, descending colon, sigmoid colon, and proximal part of the rectum from inferior mesenteric artery, mid part of rectum from internal iliac artery, and distal part of rectum and anal canal from internal pudendal artery. Venous drainage from the cecum, appendix, ascending colon, transverse colon, sigmoid colon flow through the tributary of the superior mesenteric vein. Blood from the rectum drains through the superior, middle, and inferior rectal veins. Anastomosis occurs between the portal and systemic veins in the wall of the anal canal. Because the superior rectal vein drains into the portal venous system, and the middle and inferior rectal veins drain into the systemic system, these anastomosis are clinically important areas of portocaval anastomosis. Lymphatic drainage from the cecum and appendix passes to lymph nodes in the meathery appendix and to the ileocolic lymph nodes that lie along the ileocolic artery. Afferent lymphatic vessels pass to the superamesenteric lymph nodes. The lymphatic drainage from the ascending colon passes first to the epicolic and paracolic lymph nodes, next to the ileocolic and intermediate right colic lymph nodes, and from them to the superamesenteric lymph nodes. The lymphatic drainage of the transverse colon is to the middle colic lymph nodes, which in turn drain to the superamesenteric lymph nodes. Lymphatic drainage from the descending colon and sigmoid colon is conducted through the vessels passing to the epicolic and paracolic nodes and then through the intermediate colic lymph nodes along the left colic artery. Lymph from these nodes passes to the inferamesenteric lymph nodes that lie around the inferamesenteric artery. However, lymph from the left colic flexure may also drain to the superamesenteric lymph nodes. Nerve supply of large intestine. The nerve supply to the cecum, appendix, ascending colon, transverse colon derives from the sympathetic and parasympathetic nerves from the superamesenteric plexus. The sympathetic nerve fibers originate in the lower thoracic part of the spinal cord, and the parasympathetic nerve fibers derive from the vagus nerves. The sympathetic nerve supply of the descending and sigmoid colon is from the lumbar part of the sympathetic trunk via lumbar splanchnic nerves, the superamesenteric plexus, and the periarterial plexuses following the inferamesenteric artery and its branches. The parasympathetic nerve supply is from the pelvic splanchnic nerves via the inferior hypogastric. The sympathetic supply of rectum is from the lumbar spinal cord, conveyed via lumbar splanchnic nerves and the hypogastric pelvic plexuses. The parasympathetic supply is from the second, fourth sacral spinal cord level. Peculiarities of large intestine in newborn. Large intestine is not enough developed at the moment of the birth. Shortest part of it is ascending colon. The length of it is not more than 7 cm. Cecum and appendix have more high position. Appendicepiploidy appear on the second year of life. Tiny coli are weakly developed, and Hausler coli appear after 6 months of life. Length of appendix is 2-8 cm. Osteum appendicis vermiformis is wide opened. Mucosal fold at the place of future wealth appear to the first year of life. Retrocecal position of appendix is more common than in adults. Transverse, descending, sigmoid colon and rectum are longer than in adults. Rectum has no carvings. Third mucosa of rectum is loose that predisposes to mucosal prolapse.
Thank you for attention.